the spinal cord. And you know this is where inhibition and excitation occur in pain, because you see here an autoradiograph of a spinal cord of a rat labeled with a radioactive pregabalin, and you see the accumulation in the dorsal horn of the spinal cord where pain transmission and modulation does occur. And it took then a while to try and find out what is actually the binding site, and what was finally found was that the binding site is a subunit of voltage-gated calcium channels in neurons. And this alpha-2 delta subunit, which modulates physiologically the voltage-gated calcium channel, is the site of action of gabapentin and also of pregabalin. And that was confirmed in a number of experiments. Here is one. You see here radioactive pregabalin binding in a normal mouse and in a mouse which has been bred to have no alpha-2 delta subunits. And you see there is no longer any binding in the dorsal horn of the spinal cord when you get rid of the alpha-2 delta subunit. And similarly, this is here the difference in binding, and similarly you can see the effect is also mediated through the alpha-2 delta subunit. You see here the normal mouse is vehicle, you give pregabalin, and you see that there is an increase in the pore withdrawal threshold. The mouse becomes less sensitive to pain. In the mice which have no alpha-2 delta subunit, you see that vehicle and pregabalin has the same effect, no effect. So that was the final confirmation that it's not only the binding site alpha-2 delta, it's also the mechanism of action. Now, how does that exactly work? In principle, you know that in a primary neuron, the amount of excitatory amino acid released into the synaptic cleft, primarily glutamate, is controlled by the amount of calcium flowing into the cell through these voltage-gated calcium channels. And what we know is that central sensitization, to a large extent, is an increase in calcium influx into these cells. So this would be a normal transmission. If you have now a state of central sensitization by nerve injury in neuropathic pain, for example, then there is an overshooting influx of calcium into the cell, and as a consequence, the synaptic concentration of excitatory amino acids like glutamate increases dramatically, and you get these overshooting pictures of allodynia, hyperalgesia, and so on, which we see as well in neuropathic pain. But as Milton said, we also see in normal physiological acute pain. All our patients after surgery develop allodynia and hyperalgesia in the area around the wound. And if you now use pregabalin binding to the alpha-2 delta subunit, you are not closing the calcium channel. This is not a calcium channel blocker. You are down-regulating the channel to normal function. Therefore, you can still perceive pain, but the hyperalgesia is gone, the allodynia is gone, the central sensitization is gone. And this is pretty much the main mechanism. There are a number of other mechanisms which are currently under discussion, but none of them have been proven to be relevant to the extent that this mechanism is the driving force behind the effect of pregabalin. Just to illustrate that also from a calcium point of view, you see here on the left hand a injection of placebo with the calcium concentration in the cell, and you see then the effect of pregabalin on intracellular calcium concentration, and you see exactly as to be expected, you are down-regulating influx, the intracellular calcium concentration comes down. One of the interesting reasons possibly why the drug is so effective in neuropathic pain is that in damaged neurons there is an increased expression of alpha-2 delta subunits. You see here the green is the control animal and blue is the animal where they have put a ligature around the sciatic nerve, and you see as well in the dorsal spinal cord as in the dorsal root ganglion, there is, as a response to nerve injury, an overexpression of alpha-2 delta subunits, which means that your drug is more effective in damaged neurons than in non-damaged neurons. So in summary, gabapentinoids or alpha-2 delta modulators bind to the alpha to delta subunit of voltage-gated calcium channels. Here they reduce calcium influx at the presynaptic terminals. As a consequence, hyperexcitation goes down because you reduce the release of excitatory neurotransmitters, primarily glutamate, but also substances like substance B. And if you think about it, then this explains all the mechanisms of actions of pregabalin. In a nociceptive pathway, you have an analgesic effect, or an anti-hyperalgesic effect, to be more correct. In a central nervous system, you have an anxiolytic effect, and in an epileptic fit, you would have an anticonvulsant effect by the reduction of excitation in the nervous system. And that explains why you see now an increasing spread of indications of pregabalin. For example, in the new Canadian psychiatry guidelines, pregabalin is now the first-line treatment for generalized anxiety disorder. And we all know that there is an anxiolytic effect of pregabalin, and we can actually use that, as I will come back to it. Now, just to explain the differences between the two drugs, gabapentin was the old anticonvulsant, which was then discovered to be a drug useful in pain. When this had been discovered, pregabalin was developed. And pregabalin has exactly the same mechanism of action, but it has just simply a better pharmacokinetic. So you see that overall there is a higher, that's even pharmacodynamic different, a higher potency. You need less pregabalin to get the same effect as you get from gabapentin. You have a not saturable absorption, which is a problem with gabapentin. When you double the dose, you don't get double the plasma concentration because there's an active transport mechanism in the gut wall which is saturable and limits uptake. And you have a better bioavailability, and in particular in our chronic pain patients, twice daily intake because of longer half-life in comparison to gabapentin makes it much, much easier, for example, for people who work to take a breakfast and a dinner dose. Most of my patients forget their lunchtime dose, and that always creates problems. So there is an advantage there too. Just with regard to the linearity, you see here, typical for a saturable bioavailability, that with increasing doses, the curve gets flatter and flatter. So doubling the dose doesn't give you double the plasma concentration, which means that you're actually using more and more, but you don't get as much out of it. For pregabalin in the dose range we are routinely using, there's a linear relationship between dose and plasma concentration, which makes titration and dosing much, much easier. Now, first indication, neuropathic pain, and that is not only chronic neuropathic pain. I'm just emphasizing here again, a lot of patients after trauma and surgery have a neuropathic pain component. When you see them on the first day after the injury or on the first day after the operation, and a lot of acute pain services I have observed are overlooking the acute neuropathic pain and not dealing with it, and often then using high doses of opioids in a situation where other drugs would be more appropriate. So no neuropathic pain here is just a summary statistics. These are the responder rates for 50% pain reduction. So the tough criterion, you know, there's a 30% responder and a 50% responder rate. The 50% responder rate, and you see a dose-dependent effect of pregabalin throughout the indications. And if you look at the other global improvement, global impression of change of patients, then you see also that in red are the responders in the opinion of the patient. There is also a dose-dependent improvement in patient global impression of change. In parallel, and we see that very positively, neuropathic pain is the chronic pain which is worse at night. It is not really worse at night. It is there 24 hours a day. But patients feel neuropathic pain as being worse at night. And they report it. It's, to me, really a diagnostic criterion. Because if you have osteoarthritis or musculoskeletal pain, you can usually find a comfortable position. With neuropathic pain, there is no comfortable position because it is not dependent on position and movement. And as a consequence, patients tell you routinely, pain is worse at night. And therefore, drugs which are helping sleep improvement shown here are very, very helpful. Pregabalin is also, together with gabapentin, these two drugs, the group of drugs which are effective in central neuropathic pain. For example, pain, I'm dealing a lot with patients with spinal cord injury because we are looking after the Western Australian Spinal Cord Injury Unit, and here is one of the Australian trials actually, and you see again, not as dramatic the responder rates, but still for a very complex spinal cord injury, central neuropathic pain, a profound response. And pregabalin is the first drug which was actually approved by the FDA for central neuropathic pain around 14 months ago or so. Again, patients' global impression of change. You see here, it's a very interesting indicator. I don't know how many of you are involved in clinical trials. When this was first brought out, we also thought, nonsense is this? Global impression of change. So it's very simple. You ask the patients, are you worse, are you unchanged, or are you improved? But it's actually an extremely sensitive tool, as you can see here, if you compare the placebo group to the treatment group, for what patients experience as a result of treatment. And I'm always, again and again, impressed with the benefits the simple question can actually give you answers to. What about discontinuation? There are adverse events with pregabalin. You see here 21% of patients discontinued because of an adverse event with pregabalin, but bear in mind 13% discontinued because of adverse events with placebo. You know that in chronic pain patients there's always a very high response rate for placebo, as well efficacy as adverse events. But clearly, if you look at lack of efficacy, you see there are significantly more people who discontinue placebo because of lack of efficacy than pregabalin. What are the main problems with pregabalin? This is again a summary statistic of a few thousand patients. And you see here, I have highlighted that in yellow. These are the three major problems patients will report: dizziness, somnolence, and then completely unexplained peripheral edema, which is a big problem in some patients and even needs sometimes to lead to discontinuation of the treatment, even if it is effective, because it is impairing patients significantly. So these are the really important side effects you will see. What is the result? By now, pretty much in every international guideline, a calcium channel alpha to delta modulators are one of the first-line treatments for neuropathic pain. And I don't know how many of you are working in a chronic pain environment, but clearly from a risk-benefit ratio, this is the drug of choice for neuropathic pain, and the only competing drug increasingly becomes duloxetine as an SNRI, which is you see there is slowly moving up to first line or from second to first line in many guidelines with increasing data. But I personally think that really we have now a situation where either SNRIs or alpha to delta modulators are the two first line treatments I usually start patients on, depending on the picture I see. Now, bearing in mind that even acute pain has a major central sensitization component within of hours after tissue injury, it is not surprising that there is now a flood of meta-analysis on the perioperative or pre-operative use of gabapentin or pregabalin. I've barely seen an area where there are so many meta-analysis, and every time you look in the literature there is another meta-analysis. The one which I like most, just because it is done so carefully, is this one. It's by the group around Eija Kalso. You may remember the last IISP president from Helsinki in Finland, and they have done a very, very good job in looking into these effects. But there is a newer one in the British Journal of Anesthesia, for example, from last year. The overall results are clear. A single dose of gabapentin or pregabalin given preoperatively, consistently, you see that here, it's barely unnecessary to do a meta-analysis, consistently improves pain relief in the next 24 hours after surgery, and consistently, and here you really wonder what a meta-analysis can give you if every data point is significantly on the benefit side of every single study, significantly has an opioid sparing effect.